غايه الاهميه لانها بتتناول البري سكير، ويسعدنا طبعا وجود الاستاذ ايمن كركر. هو غني عن التعريف ويجي معانا السنه الثالثه على التوالي، والكونتريبيوشن بتاعت ايمن كومبليكيشن واضح للعيان. مر يعني ميني شابتر التكست بوكس، لغايه السي، الدياليسيس سيرفيس، هيمودايليتريشنز، انشطه كتيره جدا الدكتور ايمن نشر فيها. النهارده جبنا ديفرنت اسبكت غير الكلام اللي قاله قبل كده على الفاسكولار اسيس من النيفرولوجي برسبكتيف. فهنبدا بالنيفرولوجي برسبكتيف، وليه الدكتور ايمن سعد هيتكلم على السيرجيكال اسبكتس. اتفضل طيب.
بسم الله الرحمن الرحيم. Dear colleagues, it's my pleasure again to say how I'm pleased to be around again here with you on this 5th international course on hemodialysis. As you can see from my first slide, it shows this kidney center where I work. This is in Dammam in Saudi Arabia in the Eastern Province. The name of the center is called Kano Kidney Center. It belongs to Ministry of Health, but the reason it was called Kano Kidney Center because there was a generous family called Kano family who donated something like 45 million Saudi riyals to build this 4-story building, which contains all clinics, hemodialysis, peritoneal dialysis, pre-transplant workup, and post-transplant follow-up, including all the also details like CRRT services, online blood filtration, plasma exchange, all the services related to kidney diseases, including a lab and pharmacy. I'll probably talk to you more about this in later detail, really. And today, what I will go briefly over vascular access from the nephrological point of view, and then give you a little bit of our experience, what we have done really to improve the standard of vascular access in our center and in our area. This is, as you can see, this is remind you of the map of Saudi Arabia, and this is the map here, as you can see. This is where I work, and this whole region is called the Eastern Province region, Eastern Province, and this is close to the Gulf side, as you can see, to Bahrain, to Dubai, Emirates, Qatar, and Kuwait. We are not far from there, about like 1 hour by flying, or maybe half an hour to Bahrain over the Causeway Bridge. The central part for Riyadh and the central region, this is the western part, Medina, Jeddah, Mecca. This is the north province and this is the south. So we are more on the east coast, eastern province of the region. As you know, vascular access for patients with chronic kidney disease or end-stage renal disease is vital. It's in fact their lifeline. Without vascular access, we cannot dialyze them, and then the consequences will be poor. And so far, we have the major really types of vascular access we have is the arteriovenous fistula, arteriovenous graft, and the central venous catheter. Those are the 3 major vascular access we use to access the blood, to take it over to the hemodialysis machine to do proper hemodialysis. Now, the type of vascular access is associated with patient outcome. In 2000, the National Kidney Foundation in the United States, through their pre-Doki guidelines, practice guidelines, they established a definition for ideal access. What is the ideal access? Basically, it's the one which delivers a flow rate adequate for the dialysis prescription. So we need a good blood flow rate. Second, it should have long use life. So it shouldn't last like for a week or 2 or a month. We need it for a long time to keep doing the dialysis. And it has low rate of complications. And what are these complications? For instance, low rate of infection, low rate of stenosis, low rate of thrombosis, or aneurysm, or even limb ischemia. So it should be almost free if possible from these complications. Now, although no current access type fulfills all of these criteria, still native arteriovenous fistula probably the closest to this definition, maybe the best available for us at the time being. And the reason for that, because if we look at what we have of the tunnel catheters, catheters have been associated with so much problems. For instance, increased risk of luminal thrombosis, increased central venous stenosis, inadequate blood flow rate, and this will affect the adequacy of dialysis, increased risk of infection, increased risk of hospitalization, and mortality rate with catheters more than grams and grams more than arteriovenous fistula. And on top, again, we get high costs of this because of the about adequacy of dialysis, and I'll tell you more about it in a minute. If we look at the graphs again, graphs are not as good as the fistula also because, again, there is increased chance of graft stenosis, there is a 5-fold increase in infection risk, and there's poor long-term patency. After sometimes they might close, they need to change them. And there is also high level of complications and interventions. We need to keep to ask the help of the vascular surgeons frequently because of these problems. And again, with frequent infection or stenosis or lack of enough blood flow rate, this affects also the quality of dialysis and the adequacy of dialysis. And if you can see, I've been focusing a little bit about the adequacy of dialysis because really it's important. You might find some patient doing in your center 4 hours hemodialysis, and the same patient come to me and do 4 hours. Maybe my 4 hours is not good. After 6 months, you may end up this patient in ICU or in the emergency room, whereas the one who's doing 4 hours in your center is doing very well over many years to come. And the reason for that simply is because the adequacy of dialysis is good. We're doing good 4 hours dialysis. And the way to measure this adequacy, how good is the dialysis, we always look at KT over V, or the adequacy of dialysis. And basically, KT over V stands for K for the clearance. And we look by this at the clearance or the removal of small size molecular weight toxins, endouremic toxins, like urea. And this K stands for clearance of urea, for example, T for the time during the dialysis, and V stands for the volume or the patient's total body volume, where the urea is distributed within the system. And by doing this equation, KT over V, we always try to aim, if possible, to achieve something like 1.4 or more of this equation. And I will tell you why we would like to have that. Because if we are having KT over V more than 1.4 or more, you can see the number of hospitalization patients is much less. Whereas if we're talking about KT over V less than 1.2, you can see much more hospitalization for these patients. So KT over V matters. And if we look at the survival rate as well, you can see here, if we have 1.4 or more, you can see survival rate is much better, it's the highest. But when we go down below, if you go below 1.2 or even less, the survival rate is lower and lower. So we should always aim at higher KT over V in order to achieve good survival and less hospitalization. As you can see here, on the y-axis, shows the percentage of patients with KT over V less than 1.2. Okay, and this is the vasculitis. And you can see patients with catheters, more than almost 28% of them here in this study, showing that they have KT over V less than 1.2. Whereas with fistula, much lower than that, 19%. And if we look at, again here, the hospitalization rate, you can see patients with catheters, they are more prone to hospitalization than patients with a graft, than patients with fistula. So I wouldn't love really to have catheters. And if we look at the causes of admission to hospital, what are the causes of hospitalization? And when you talk about causes of cardiovascular disease, infection, the problems of vascular access itself, or GI bleeding or others, you can see the yellow bars here, always associated with more with the catheters really, more than the graft or the fistula. So whenever there is a catheter, there's more tendency of complications, any one of those ones, which may lead to hospitalization, more hospitalization. And what about talking about mortality? Not only about mortality, the increased risk of death. Again, you can see patients with catheter are more prone to die than patients with graft or patients with arterial venous fistula. What about the cost? Even the cost is higher. This is comparing the catheter and the graft and the fistula, and see on the y-axis the cost in dollars. And this is the first year of the creation of the vascular access. And as you can see, the first year these cost about $87,000, whereas the graft, 76 lower, and fistula much lower, $68,000, the cost of looking after this access. Even if you look at the second year of the course, although the cost is lower in the second year, it's still catheter costing more money to look after than the graft or the fistula. So from these quick really slides and studies, you can tell easily that that there's no wonder that the arterial venous fistula gives us better capability. There is less risk of infection, less hospitalization, less mortality rate, and lower cost. So why should we always go to a fistula and forget about the catheters? And if we go back a little bit, few years back, in the beginning of this century, about 2002 here, in this paper, which was the first paper published, or the earliest, if you like, paper published by the DOPS group, or DOPS studies. I don't know if you are aware about the DOPS, but DOPS stands for Dialysis Outcomes Practice Patterns Study. This is established in the United States in 1996 to look at the practice patterns, how the people doing dialysis in different countries. They started in the United States, then they looked at Europe, they moved to Japan, and more recently we conducted with them, collaborated a study in Saudi Arabia, a pilot study, and I'll show some of the results later. Amazing, it tells you what we're doing good or doing bad, how much the standard of care will be, how much vascular access we have, and then we compare that with other countries. So when they started their current system in the United States, see how much they're doing vascular access, and they compared that with Europe. And they were really surprised. It was like a shock. Because look here, this is comparing the prevalent patients. Prevalent means patients who are on dialysis for longer time. Incident patients who are new, who are going to start dialysis now. So in prevalent patients, they noticed that only 24% of their patients actually having fistula. Whereas when they compare that with Europe, look, in Europe, almost an average 80, in France 77%, Germany 84%. In Italy, 90%, Spain, 82%, even UK at that time was 67%, higher than them. So they were really surprised. They have very low level of vascular access in the form of arterial venous fistula. When they also compared their incident patients, new one was starting dialysis, again the fistula was only 15%, very low. They were way behind also Europe, where they were talking about 60s and 70s or maybe 80s in the percentage. And that prompted the United States to say, look, we have to stop here. We should promote arterial venous fistula because we have so much trouble of hospitalization, mortality, and costs of this fistula. So what they've done in 2003, after looking at DOPS study, said, okay, we have to aim at reach our patient to 40%. They worked hard, all the renal team, all over USA, and in 2005 they achieved the 40%, the target. Then they said, well, that's not good enough. We should raise our bar to reach 66%, something similar to what Europe at that time was trying to achieve all over the Europe, 66%. So they did work really hard. So until January of this year, 2012, they achieved 60%. 60. They haven't reached the target, which is 66%. In June, I'll show you in a minute a slide, they reached 62 in June recently. It seems they're working hard. However, having said that, looking at the incident patient, they set the target, their line, about 50%. But so far, the beginning of this year, again, they only achieved 20%, which was still very difficult to achieve the fistula. And I think the reason for that is maybe this fragmentation really of the pre-dialysis care, which I know there is a lecture about it in this meeting. The value and the importance of pre-dialysis care is very important because you see the patient early on, you prepare the patient. When they reach end-stage renal failure, before ending, you start to educate the patient, introduce the patient to vascular access, or maybe peritoneal dialysis. Maybe you have to think of catheter in the first place, or maybe the patient will, he or the doctor decide to go for hemodialysis. Then maybe you can establish the fistula first. So when the patient in need of dialysis, you don't rush in the emergency room to insert internal jugular catheter or femoral catheter. The fistula already is there, established, mature. You can start using it, and then you avoid complications with those incident patients. But I think that's the reason, because of pre-dialysis care maybe is this fragmented. And this is a recent DOPS study, and this is what we've done also with DOPS in the United States. I'll show you that what our results. But this is in June. This is June 2012. You can see here 62% they achieved, and the catheter went down to 20%. This is graph 18%. And maybe it's summarized more clearly in this slide. You can see they achieved now networks in USA on average 62% AV fistula, which is great improvement if you remember from 24% up to 62%, catheter down to 20%. graft 18. That's not bad. They are progressing very nice. And this is show you what those really we've done in Saudi Arabia lately. We just finished the data, actually, the results. This is Saudi Arabia here. And our study, what we have done really, we achieved now something like 73% all over Saudi Arabia of the fistula, arteriovenous fistula. Little bit of grafts and little bit still of catheters, as you can see there. So if you look at Saudi Arabia, for example, we are better than Spain, United States, Belgium, Sweden, and Canada. But still, we're close to the United Kingdom, but still less than Italy, Australia, New Zealand, Greece, and France. Germany and France. The best so far is Japan. Japanese, they are reaching more than 90, almost 93% of their patients with arteriovenous fistula. It's very small. Again, I showed you this a while ago, but I was going to talk to you or show you our little experience, how we were trying to improve in our area, in Eastern Province here, and in particular in our Canopy Center, improve the level of arteriovenous fistula use and avoid, if possible, as much as we can, the catheters. Again, this Canopy Center, which I mentioned earlier, it's within a big hospital. They call it the MAM Medical Complex. It used to be called the MAM Central Hospital, but because it's expanding with so many centers, cardiology center, kidney center, dental center, radiology center, infectious disease center, name it. All the centers become more centers rather than one only big building, plus the tower which contains all medicine and surgery. So they call it medical complex, and I think within a very short time the name will be changed into a medical city, maybe the MAM Medical City. This center, in fact, is the main referral center for all the Eastern Province region, in all the east part of Saudi Arabia. All the referral systems. Although there are other units and centers in the area, but this is considered to be as a referral center. And therefore, you don't see there's no wonder that we are having about 80, now we're having more than that, 80 modern hemodialysis machines. We perform dialysis for more than 400 patients at the moment. And there are about 5 to 10 new patients weekly requiring initiation of dialysis treatments. We can see it's quite a busy center. All the time we're having new patients. And just give you a flavor of what we used to be and what now the situation. This is the time when I joined the hospital, so I'm an old man, I can tell. This is from 1982. We used to have, I think, 4 or 6 patients when we started on hemodialysis. And you can see the progressive increase in number of patients over the years. Until now, we can see we have now almost 400 patients. And look, with this increase and new patients every week, there is definitely increased demand for vascular access. We cannot treat all those patients out of catheters. There must be a plan. There must be something to be done for these patients. Now, mind you, this is only in Canopy Center, only in our center. But if you look upon all the Eastern Province region, this is in 2001. We have something like 800 patients on dialysis all over the area, all hemodialysis used all over the area. And look, in 2004, just 10, 11 years more, we have doubled the number of patients. 1,600 patients currently on hemodialysis. And look, there is continuous demand for vascular access. So you need really a team, proper team to look after that. This is what we used to do, unfortunately, before. This is our situation. We used to have more than 70 or 75% of our patients at Canopy Center with catheters, unfortunately, I would say. And we have only now 25 or maximum 30 patients with arteriovenous fistula. Ask me, were we suffering? Yes, we were suffering a lot. We used to have no dialysis adequacy on most of the patients, 0.8, 0.7, 0.9, much below than what we should do. And increased infection rate, name it. So much infection, admission to hospital, cost, antibiotics, everything. Sometimes you remove the catheter and find difficulty in inserting another one. Increased hospitalization, and again, too much cost, and bed occupancy rate is high. So we decided to do something. We said, well, this is not good enough. We should do something. How can we improve the situation? So the aim was for Canopy Center and also the areas, all hemodialysis centers in Eastern Province, was to enhance collaboration with an established and enthusiastic vascular surgeon. We used to have a vascular surgeon, but he had priorities. He goes for aortic, for other vascular surgeon operations, and leave at the bottom of his list our need of fistula. So we always end up at the end of surgery, either he doesn't have enough time or he will finish quickly and do some catheters. So So we never had enough fistulas to be done. So we thought maybe we can see somebody from other areas who can help us and collaborate with him and do the vascular surgery for us. The aim was obviously to avoid or reduce catheter fixation rate, increase arterial fistula rate, improve the quality of hemodialysis, and decrease morbidity and hospitalization rates as much as possible. So what we do, the Vascular Access Program, we call it a program for collaboration, started in July 2008, so you can almost say 2 years ago. The program was shifted from admission, we used to admit patients initially to hospital. We shifted to day surgery, so patients come in the morning under local anesthesia or even general anesthesia and be discharged in the afternoon. So there's no bed occupancy rate high, minimize it as much as possible. That was established in January 2011 with encouraging the team and all the support were given. Initially, the visits of this vascular surgeon who used to come to us from Riyadh used to come every 2 months once. And then with the good results we had and his enthusiasm and the increasing number of patients said, look, can you make it every month? He said, yes, I'll try. And then he started to come on a monthly basis from December 2011. So almost you could say from the end of last year. So all of our patients underwent echocardiogram in our center. We have an echocardiologist in our center with a state-of-art echocardiography machine to evaluate patients. Patients requiring general anesthesia underwent full evaluation by the anesthesia team. Some patients undergone Doppler ultrasound of the upper limbs and neck vessels, just to ensure that everything was okay. And then some patients require CT or angio for neck vessels and superior vena cava. The evaluations and investigations for all patients were done in our center, and hemodialysis was performed 1 day prior to surgery, just to make sure are ready for surgery and in good status, general status. The coordination that was in our center. Now, at the regional level for the Eastern Province region, we received patients from other centers of our region 1 day before operation. Clinical evaluation, investigations, and consultations, if required, were done through our outpatient department. And dialysis sessions were arranged 1 day as well before surgery at our center. So those patients coming from our area, we used to dialyze them 1 day before and just to make them also ready. On the day surgery, trained and well-experienced and very cooperative day surgery team of our hospital started their work 1 day before the procedure. What they've done, completion of files and review of all investigations were done 1 day before the procedure. Patients were received in the reception area at the day of surgery, in the reception area of the surgical unit. Clinical assessment and review again of the investigations were rechecked by our staff. Intravenous access and other pre-operative preparations were done by nursing staff, and the patient was sent to the operating room once scoped. Again, post-operative, once the surgery is done, post-operative patient was received back in the reception area and managed by our staff. Not our staff, I mean the Kidney Center, not the hospital one. Within a period of 3 to 4 hours, patients were ready to be discharged home after appropriate evaluation and assessment. So quickly within the same day. So what have we achieved? Let's look at these results. Over 2 years, you could say, we had 16 visits from this vascular surgeon and the team. And on each visit here, it can show on the y-axis the number of procedures that were done on each day. So you can see for visit 1, he did 33 operations or procedures. Visit 2, 31, 22, 33, and so on. And you can see, for example, on visit 5, we've done 51, which was excellent, really great achievement. The reason for that, because he did it over 2 days. He said usually he comes and stays for 1 day. On that visit, had 2 days. So we achieved more. Some even more, like here 23, and some of them more, because although within the same day, but they started early, very early in the morning, and they stayed till late hours in the evening to manage more patients if we have more patients, and if he cannot do, stay another night. So over those 16 visits, we managed to do between fistula graft and catheters, 377 patients, which was excellent, I think, number. From Kidney Center, our center, there were 321 patients, and from the region, other nearby hemodialysis units, we achieved 56 patients, which was based on to other centers surrounding by. This is showing you what we've been done. We are almost at like 291 arteriovenous fistula from 377, 291, almost 300 fistulas, 45 grafts, permanent catheter 24, and some other surgeries like removing the graft or aneurysectomy, or ligation, or a very small number of procedures that need to be done. And mind you, the catheters that were done, one may ask why you do catheters if you are trying to avoid catheters. Some patients of those ones who are planning soon early transplantation, they would like to go for transplantation, or some patients who refused to have an access, we were forced to insert a catheter. But mind you, the catheter which was inserted by the surgeon, by the vascular, was much better, or those who were much better than what we did. I'll show you the result. Reduced very much the infection, the clotting, even the type of the catheter that was used, much better than what we used to have, because he advised us on a better type of catheter to use. And one way some people look at it, like in the States, how to assess really the success or whether this fistula can be used. Following the operation, 4 to 6 weeks, there should be an ultrasound to be done to check this fistula which was created. If the diameter is of 4 millimeters or more, and if the blood flow rate is of 500 ml per minute or more, then it indicates in most cases, more than 90%, that this fistula is very likely to be used for hemodialysis and in purification. And from the total number of patients, we achieved from this slide more than 90% success rate of the fistula that has been done. Very small percentage, about 7% failure rate of some of the fistula. And major of those ones, they were either fistula was becoming too deep down that you have to raise it up a little bit, or there were some abnormal vessels or accessories blood vessels. I'm sure the vascular surgeon will tell us more about it. But I'll show you this slide. If you'd like to focus with me on this slide to show really what really happened, you can see the value of the teamwork when they work together, the achievement. As you can see on the x-axis, the number of the year. We started year 2006 and 2007, 8, 9, 10, 11, and 12. From 2006 to 2009, 6 to 9, this is before our program established. You can see in the yellow line, this is the total number of patients. In the blue one is the arteriovenous fistula allograft together, and the pink one is the catheters. Okay, and you can see from 2006 to 2009, though the number of patients increasing, yet the fistula graft almost remained the same. There is increase, but minor, is not much. But look at the catheter was increasing over the years. Once this program started in 2010, look, the number of patients is increasing, also fine. But look at the fistula graft, progressive improvement in the fistula graft, and look at the catheters going down. Something we will hope that was our aim really, to reduce the catheter use and improve the fistula, and for us to expect the graft to prevail in the center. And this is to show you really what we have achieved from some of these results. You can see this is before 2006. As I told you, we have something like 25% for patients who are having fistula, and 35% improved between 2006 and 2009. But following the program, there was a great increase up to 78%. That's what we achieved now in our center, 78 or 80%, or even better than the average of the whole Saudi Arabia, as I told you, 73%. If we look at for the catheters, we achieved the aim really almost by dropping down from 65% down to 18% now. We have a total of the patients of the catheter. And this is the previous done slide really. Now, even with the recent visits, we have a better rate, lower than that. I think below 15% we have only catheters. And if you look at the infection rate, is significant really improvement from 6.6% down to 0.6%. Great improvement. And much less was admission to hospital. I'll show you that in a minute. And this is showing you the clotting even down from 5.1 to 1%. We used to use a lot of urokinase or plasminogen activator really to declot or remove or dissolve those clots really, which are formed in the catheters. Big headache and cost again. But that was fortunately very much reduced the clotting. Blood flow rate, which is very important for adequacy of dialysis, to achieve good KG over B, improved from on average 200 to 300 ml per minute. Again, KG over B improved from 0.88 up to almost 1.3, which is great improvement really, KG over B. Hemoglobin has also improved because of adequacy also of theirs, from almost an average 9 to almost 11 grams per deciliter. And here you can see even the erythropoietin dose was reduced from 75% down to 67%. And I think this is due to adequacy of dialysis better and decrease of the infection, which you know infection really resists the effect of the protein use, one of the reasons. Even serum albumin, nutritional status of those patients improved from average 3.2 to 3.7 gram per deciliter of serum albumin. And look at hospitalization, I told you, with less infection, less clotting, loss of this problem, even admission also reduced from 6.1 down to 3.8%. So in conclusion, as you have seen really, arteriovenous fistula should always come first. Avoiding temporary catheters and or permanent catheters increases blood flow rate, improved adequacy of dialysis. There is significant reduction in infection rate, and this is also an experienced and interested, I must say, interested vascular surgeon and motivated teamwork really. Very essential, very important for the success of such a program. And in patients who are not suitable for creation of arteriovenous fistula or graft, I see some a better quality catheters inserted by expert may give rise to a better blood flow rate, and less infection rates, and less clotting even. And this surgery management demonstrates the safety, friendly, and probably more cost-effective way of care of those patients. So you don't need really to admit patients to hospital to do that. And my conclusion to you is always think fistula. Fistula should come first. Thank you very
I have a question about any precautions at your program regarding cardiac status of the patient, and if not, are you aware of any recent studies that compare fistulas, burden fistulas versus catheters in cardiac patients?
Not really, no. Well, that's the second part of the question, not really. But catheters, as I say, catheters per se on the cardiovascular system, maybe a surgeon can maybe tell better than me with their experience. I haven't seen really much difference from that point of view. As I said, for all patients we evaluated by echocardiography, which is really advanced machinery, evaluating valvular status, the pericardium, the size of the ventricle, the diastolic function of the heart, and all the patients really before the operation, just to make sure that our patients are in good status for surgery. But coming back to the question whether there is a difference between the catheter and fistula, to be honest with you, I'm not sure of that. Thank you.
Professor, thank you very much for excellent presentation and excellent review for this valuable knowledge. I have many questions to be covering more about arteriovenous fistula. I think is also my conclusion in our locality. I personally am satisfied more with the arteriovenous fistula and endogenous material for the fistula result. Don't use the synthetic except if there is no rule or there is no hope for endogenous fistula later on. But the problem in our locality is almost always the delay for the time for creation of the fistula, because the awareness for the patient here is so difficult, especially in the lower economy. Many patients refusing to do the fistula because they believe that this is the start of dialysis and not after several months. But with good education and good awareness, I think this gives excellent result for long-term patency for this fistula, and we try more and more, but we still focus with many patients refusing to do the fistula except when just come for high level of creatinine and they need urgent dialysis, so we force them to go to the central venous catheter until you have an endogenous fistula and contour and so on. But I would like to take the opportunity to ask one main question. Is the patient presented not with cardiac problem but with hypotension? Because I see many patients nowadays in our locality even they will start dialysis by presented to us with hypertension. And you know, this is one of the main cornerstone for evaluation for the patient to do whatever arterial fistula or cystocram. Not only looking for the vein, but I look for the blood pressure, because this is the main cornerstone. If still hypertensive, how to deal with, how to improve the blood pressure to shift him from the central permanent caster to the fistula. So I need your experience at this point.
I must say I haven't seen much or many patients with hypertension before, except for those patients who are prevalent patients who are on dialysis beforehand. New patients, unlikely, sometimes they are in fact hypertensive. But for patients who are already on dialysis beforehand, prevalent patients, some of them you might be right, there are some of them maybe they are having hypertension or on the hypertension side. And I think the major reason or cause of that, I think, is because we are feel like dialyzing them maybe, or removing too much fluid from them in trying to achieve a good target dry weight. And I've seen few patients, even lately, our staff are over-enthusiastic in removing fluids. And I think a better assessment of the dry weight is very, very important in these patients. If we remove too much fluid from these patients, they will be, as soon as they start dialysis, they will be with hypertension and sick out and frequent hypertension episodes during dialysis. So for example, if the patients are assessed, like say for example, the dry weight is 70 kilograms, assessed whether by bioimpedance or by clinically or by any other means, then if that's 70, then we should maintain 70. We shouldn't try to aim at reducing that to 68 or 67, because that tends to keep the patient in hypertension. That's one thing. The other thing, the other reason, some of the patients following their control of their body volume fluids by the frequent dialysis and removing fluids and trying to achieve the dry weight, which maybe has already been achieved, is the problem is that some patients, they still on their antihypertensive medications, and for some reason we forget, our staff, ourselves, forget that those patients, they're still taking their medication. We should discontinue this antihypertensive medication, because we prescribe those medications when they were on the hypertensive side. Now, following dialysis and removing of those fluids and achieving a dry weight, thank you very much. We should stop these antihypertensive medications. Otherwise, patients will also continue on having hypertensive episodes. So maybe a re-evaluation, I would say, a re-evaluation of the patient, and also make sure the cardiac status also is okay. Not the patients that having cardiac disease, or maybe sometimes of those maybe patients who are, on the other hand, maybe not dialyzed well, maybe twice a week, or they are not compliant, if you like, with dialysis. You prescribe it 3 times per week, every time 4 hours they come, they finish 2 hours, and thank you very much for leaving. Or they come twice per week, and they don't show up on the 3rd dialysis. And with time, they might develop precardial effusion, and they may affect even the cardiac output, and those patients go end up with maybe hypertensive episode. So what I would say for those patients with hypertension, I will re-evaluate these patients again and see what is the likely cause. But probably I will focus initially on the dry weight, make sure that the dry weight is achieved properly, as they are not on the very dry weight, if you like, and then check their antihypertensive medication on all.
It's very good. Just 3 points. As you said, most of the points you covered, but we have not to forget about protection of acidosis. Most of these patients are acidotic, so correction of blood pressure will be difficult and there is some metabolic acidosis. So we have to take attention for acidosis by giving sodium bicarb. Also, sometimes patients correct anemia. You can support blood pressure. ESA therapy will correct anemia and will support the cardiovascular system. And number 3, as you said, look for pericardial effusion and supporting the myocardium as well, especially if there is ischemic heart disease. Also, very important, I can accept some overload to keep good blood pressure. No need to make the patient very dry in phase 2 cycle. So, acidosis, anemia, perfusion, supporting myocardium. These are those ones. And besides, of course, during this hypertensive period, I can give antiplatelet, anticoagulant, till the patient start to gain good blood pressure.
Thank you very much. So, if you allow me, I'll go back to the acidosis part really. We used to have that problem in the old days when we used to use acetate. Yeah, when we used to use acetate as a buffering solution for dialysate. But ever since we start to use bicarbonate as the buffer dialysate, if you like, we haven't had that much problem really. Most of the bicarbonate is corrected for these patients. So it used to be maybe a problem beforehand, but in our experience with the using of bicarbonate as dialysate, most of the time bicarbonate is corrected. So it may not be as a common cause nowadays for us.
I think the story is the patient starts with dialysis. So steady is even as well.
And that was my question, whether this is a new patient or a prevalent patient. Yeah.
But even in our experience, when you are putting your patient on bicarbonate, still many of these patients need additional oral sodium bicarbonate.
Yeah, we will keep patients on bicarbonate.
Just one. So before, if the hypotension is still present after all this precaution, I think there is no way to be a bold statement. There is no way for the access except permanent.
Definitely, because otherwise the hospital here mature already.
In case of thrombosis, fistula or permanent catheter, I mean blocking of permanent catheter. What is the role of urokinase in solving this problem? Is it the job of nephrologist or is it bigger to refer the patient to the vascular surgeon? I mean, silent or sudden stop of the vessel.
With the catheters, in our experience, with the catheters, you face this quite often. You find clotting quite often. You see so much with the catheters. We used to use ourselves, I mean our colleagues, nephrologists, to deal with by injecting urokinase. More recently, we resorted more to plasminogen activator using it because it's more effective. Though it's more expensive, but it's more effective really in using it. However, having said that, urokinase can work also, and it should work by declotting of the catheters. But this is again the problem. You see, if you frequently encounter this clotting and you sometimes you try to do it to declot or dissolve it, like that was by urokinase or plasminogen, tissue plasminogen activator. But it's costly, it's frequent, it's a headache, it's not dialysis, the blood flow is low, and you may end up having eventually dialysis
comment before we leave because you asked about who will do this job. The nephrologist or the vascular surgeon. Okay? To solve the clot inside the heart. I believe this doesn't need experience of the surgeon in this area. It's a simple job. It can be done even by the nurse under guidance of the nephrologist. If you present with him with a custom which is included, he can just document everything for the X-ray, location, everything, and can calculate the proper dose according to the diameter of the abdomen of the custom and inject the lytic therapy, whatever is kinase or TBA, and follow up the situation and can solve the problem. Instead of go ahead to the surgeon who bought the custom even since 6 months. So this is not solving the problem for the patient, it's just away the patient from him. So not this point to be clear. A simple job can be done under the guidance of the nephrologist. Okay?
After we solve the problem immediately, we have to go back to the surgeon to re-evaluate the vascular access for possible anatomical problems.
Exactly. If the nephrologist see with plain X-ray or for the location of the cluster, there is some problem of kink or problem of positioning, so it can repair. But if the patient already on dialysis and the proper side and everything is okay for him several months and develops thrombotic event due to mostly because the finishing of the dialysis is not well, is not putting a proper dose for the anticoagulation heparin inside the cluster and solve this problem. So necessary to refer to the surgeon, as this he can solve the problem very easy. Except he just needs someone needs to be strong and with himself he can do this work. I would like at this point to ask Professor Karkar for his experience. Are you front with many patients with the central venous cluster liable for frequent attack of thrombotic event because with the history of them with the repeated failure of access or thrombotic events was hypercoagulable group clinical or by some level of hypercoagulability. So you recommend in this situation to maintain the patient with this intravenous cluster under oral anticoagulation so it can decrease the thrombotic event for them.
The simple answer is no. No, I'll tell you honestly, initially we used to use not good quality catheters initially, and we used to face so much frequent problems with clotting. And second thing used to be most of them inserted by our group, ourselves inserted. We are not very good, I must say, at inserting. You are much better than us as vascular surgeons. But sometimes you do it, you actually do biopsies as you're trained to do that. But we were not very good. The quality of catheters were not as good as well. But more recently, especially over the last 2 years, with our being lucky, very fortunate with this our colleague, the vascular surgeons, he advised us to use a certain type of catheters. We used to bring some of them with him. We thank him for that. And he inserted properly, if you like. And ever since, the number, as you've seen, the number of clotting and infection has very much reduced down really. So we never had the chance really, even before in the earlier times, we never put patients on oral anticoagulants for that. If there is a clotting, we manage that there and then at spot at that time. We never had to consider really put patients on oral anticoagulants.
Just a very short questions. First, in patients you are using CT angio or any study including a dye, we are considering precautions against contrast-induced nephropathy in these patients. Number two, using of calcium carbonate orally can be relied upon to combat against metabolic acidosis instead of sodium bicarb if we are afraid of sodium content, as Professor suggested.
Let me start with the second part first, really. Calcium carbonate, we don't use it to treat acidosis usually. It's usually we use it to either correct calcium slow, or I use it as a phosphorus binder because of hyperphosphatemia. But sodium bicarbonate, as Professor said also, we use it for patients. I use it more frequently, even patients pre-dialysis stage, really. For two reasons. One, to correct acidosis for those patients that are on dialysis. It's the only result to give them sodium bicarb. And second thing, there are studies which have shown definitely when sodium bicarbonate can delay the progression of renal disease. Sorry, remember
This precautions against contrast-induced nephropathy.
Yeah. I agree with you totally. I mean, we try to avoid as much the dye really. It's not because we're trying to take care of the kidney. The kidney is already probably in the stage renal failure. We don't care much really, but you don't want to have any systemic fibrosis or any problem maybe because of the dye. So we try to avoid it as much as possible. We either run it without the dye maybe, or maybe most of the time we don't do echo. Our echo really is brilliant. The machine, the resolution is quite high. And we've been very lucky with the echocardiologist who we're having very specialized and really have, as I said, the probes are excellent, the resolution is excellent. We can pick up things if we need, hopefully without the need of dye.
Only small dose of the contrast.
If that is really needed, it's really in one situation. Although we try to use those types of contrast agents that may not lead to systemic fibrosis, but you never know. You better be safe than sorry.
Professor Karkar, thank you very much for this excellent presentation. I have just a small comment. The main message of when we decided to put the vascular access in the beginning of this course, also stressing the point that fistula equal life, or the assurance of the vascular access is the most important critical step in the management of patients in the pre-dialysis care. And this is a call for the vascular surgeon to put priority, and I want to emphasize that the dominating for the team of decision making is nephrologist, because he is the person responsible about the patient. And you should depend, as you did in your program, it's very excellent because you depend on a dedicated surgeon who has a very good experience doing the best chance for the patient because fistula means life. The second point is that the decision to make fistula is not a static decision. So I can say creatinine 4 equal fistula, no. There are many factors that we should put in front of our eyes when we take this decision, like the age of the patient, the slope of creatinine or the trajectory of creatinine. So if you have a patient with creatinine 4 for 4 years, there is no necessity to do fistula. But if the creatinine is increasing progressively, despite all the measures for acidosis, hypertension, etc., I can do fistula. Fistula for the younger age patients can be done earlier rather than the elderly patient. The question for you is that how to convince your patients to fistula? Because I know the nature of our people, Saudi or Egyptians, there is resistance to fistula. So how can you convince your patient to reach this score that is exceeding many countries in Europe and the USA?
I think convincing, this is a very good question. The convincing patients to do fistula is not one-man show. It has to be a teamwork. I don't rely on myself looking to patients only. I ask the help and support of my nurse, my social worker, to go together and sit with the patient, and if possible, with family. Some people who influence the patient as well. And then we sit talk to the patient and explain to them how bad the catheters and how bad the results of that, and how the fistula is quite important for him or her on long run after dialysis. That's in the case if there is no chance of PD or transplantation. And then it is the only choice is hemodialysis. Then because you have no choice, this is the best available for you. Because if you go the other direction, it's full of problems for you, for us, for everyone. So we sit and explain to the patient all these details, and most of the time, if possible, and if the time allows, we take the patient also to show other patients in the dialysis unit. And that's what we normally do with patients in the pre-dialysis clinic before they reach the end-stage renal disease. We take patients in the tour, show them the peritoneal dialysis section, they meet some patients, and show them the catheters, how it's done, and they take a catheter, and show them the hemodialysis, how the procedure is done, what's this is the machine, this is the filter of the dialyzer, these are the tubes. And we just orient the patients what they are going to do. I think this is very, very important for patients in the pre-dialysis stage, because otherwise patients will go in shock once they put immediately stuck with a fistula, or even not fistula, the catheter, and take them to a machine. They will be really in shock and they will become so nervous they can become violent for nurses, for doctors, for themselves, their families. They may shout, they might hit, they may do anything really. And above all, they may be non-compliant patients. They don't stick to the dialysis. So convincing about the fistula performance, it is really the role of the teamwork, more than one person. It's very important to approach the patient from different aspects to convince them of the value of the fistula.
Thank you very much for this excellent talk.
I would say, since it is a common problem we face in Arab, sometimes you will say, my opinion, fistula should be done by experienced vascular surgeon. يعني vascular surgeon ممكن يتدرب في الشفا. يعني الفستلة هو فقط واحدة عشان هم 4 شخص. فلازم فستلة مع انها تبدو ماينر، انما اعتقد يجب نبحث الهايلي تريند vascular surgeon دلوقتي. ده انا
vascular surgeon interested Professor Karkar writes this statement. It was not all what was interested in this part.
No, to convince patients, in my opinion, culture تختلف حتى في نفس الوالد كوميونتي. فلازم انت ككلينيشن تبص في عين العيان وتحس بيه وتختبر مدى خوفه ومدى تقبله. انت في دماغك انك بتقول كهرباء انا عاوز اختار الفيستل. ممكن يكون تستهل بعض الجمل اذا كنت خايف تراجع الزياره الجايه. ممكن تديك معلومه الزياره الجايه تديك حاجه اقوى. ما تلاقيه ريدي قبل ما تقول فيستولا للناس بضميرها فيستولا على الارسل يعني كارثه. فقبل ما تقول انا عايزك تعمل فيستولا، انا بقول له شوف طالما انك انت كلينيكيا كويس مش مهم قدام الكرياتينين، انا يهمني انك شهيتك كويسه، بتاكل كويس، مفيش اكشن، بتنام كويس، مش هقول لك ارسل. فلازم تحط الستيتمنت دي انك مش هتقول ارسل. وبعد كده بتقول له بس في احتمال نعوزها سي. فاحنا محتاجين نعمل فيستولا دي، بس خد بالك مش معناها انك هترسل النهارده ولا بعد شهر ولا بعد سنه. انا مجرد بس احتياطا عايزك تعملها. دي بيبقى الجزء الثاني. الجزء الثالث تقول له يمكن تعوز تقول لي ان عاوزها اعملها. فبقول له لا ده انت عشان تستخدمها مش قد شهر او شهرين، فلازم تبقى موجوده عندنا. فمع ان احنا مش هنعوزها النهارده ولا بكره ولا بعد 6 شهور، بس عايزينها. طيب افرض ما عملتهاش وما سمعتش الكلام واتزنقنا عاوزنا غسيل، هنضطر لازم افهمه اللي يخوفه. هنضطر نحط ساكليبيان وبمشاكلها. فانت اعمل فيستولا وما تخافش، ده مش معناه انك هترسل. ده ممكن ترسل بعد 6 شهور، بعد سنه، بعد سنتين، انما لازم تعملها. انا اقصد لازم يكون في دايلوج بينك وبين العيان، ومضطر انك تكون هتعمل فيستولا. ممكن تتراجع وما تتراجعوش، اللي هو مش هتبصص في عينيك وحاسب الرياكشن بتاعه. فهي بتبقى انك انت كلينيشن لازم تحس العيان من انترفيو معاه. ممكن تقولها له مش النهارده، ممكن بكره بعده، وقبل ما تقولها له تفهمه ان دي مش معناها ان هو هيرسل، وتفهمه البدائل المؤلمه اللي هو استنى اخر لحظه عشان يعملها. يعني ده التصور.
شكرا دكتور محمد على التوضيح ده. فيستولا ايكوال لايف، ولازم احنا نبقى حريصين فعلا على فيستولا انيشن or initial step. Thank you Dr. Ayman for this excellent presentation. We should move to next speaker. Thank you very much.